We are very excited for this next session on gastrointestinal screening. We're going to start with novel techniques for the screening of Barrett's esophagus. I'm very happy to introduce our next speaker. She is our chief fellow and going to be staying with us for an advanced endoscopy year. She was in my continuity clinic, so I get to take credit for all of her achievements forever. Dr. Zhao, thank you for it.
Hi, everyone. So as David mentioned, I'm Margaret. I'm one of the third-year fellows here, and today I'm going to be talking about recent developments in screening for Barrett's esophagus. So I'm going to start by going over some of our current screening guidelines. Next, I'll move on to describe some of the newer technologies that have emerged as alternatives to endoscopy for screening. And then I'll close with going over some of the new endoscopic technologies we have to help with risk stratification. So just to review, Barrett's esophagus is the only known precursor for esophageal adenocarcinoma. And the way we currently diagnose it is by finding at least 1 centimeter of columnar replacement of the esophagus above the GE junction in combination with histologic confirmation of intestinal metaplasia. And so who should we be screening for Barrett's currently? We have various guidelines put out by GI societies in both Europe and the United States. And all of these guidelines really focus on identifying high-risk populations. Throughout these guidelines, the risk factors are pretty similar. So you must have chronic GERD in almost all of these guidelines, plus at least 1 to 2 additional risk factors focused on men who are older than 50, have white race, have obesity or central adiposity, a family history of Barrett's or esophageal adenocarcinoma, or a history of tobacco use. I want to highlight here one really exciting development is that in 2022, the AGA put out a clinical practice update that no longer requires GERD as a screening criteria for Barrett's. And this is really a departure from all the guidelines outlined here. And so this is really based on some evidence in the last few years, looking at groups of patients with esophageal adenocarcinoma. And they have found that over 50% of patients actually never had a prior diagnosis of GERD. And so we may have been missing out on a lot of patients who were at risk. So in terms of currently diagnosing Barrett's, we use upper endoscopy, and there are some best practices put out in our guidelines. They recommend documentation with the PROG criteria for the circumferential and maximum length of Barrett's segment. We also recommend using Seattle protocol biopsies, at least every 2 centimeters, taking 4-quadrant biopsies in non-dysplastic Barrett's. There have also been some quality metrics put out there to spend at least 1 minute per centimeter of circumferential Barrett's length, and considering spending at least 7 minutes for your entire endoscopy to optimize neoplasia detection. On top of this, guidelines recommend also use of virtual chromoendoscopy, or NBI, to maximize neoplasia detection. Despite all our guidelines and all our endoscopic technologies, we continue to miss a lot of cases of early esophageal cancer. And of all patients with esophageal adenocarcinoma, only 10% had a prior diagnosis of Barrett's. And so how can we do a better job to actually screen for Barrett's? There have been some new technologies that have come out in the last few years. The first one I'll describe as unsedated transnasal endoscopy, and that's basically exactly what it sounds like. You can insert a thin endoscope to the nose. You can do this unsedated in a clinic setting. You can examine with white light and take biopsies just the way you would do with a normal endoscope. And so this has really good performance compared to normal endoscopy. But a lot of us have never done this before. We've never seen it in the office. And this is probably because it's operator dependent, and sometimes patients don't tolerate it very well. So there has remained a need for less invasive technologies to help with Barrett's screening. And that's led to the emergence of non-endoscopic cell collection devices. Right now, the ones that have been studied include Cytosponge, EsophaCap, and EsoCheck. And they all work pretty similarly. In the case of Cytosponge or EsophaCap, you have a gelatin capsule enclosing a flexible sphere. In the case of EsoCheck, there's an inflatable silicone balloon. And these are basically attached to either a string or to a catheter. And the patient can swallow it in a clinic setting. The person administering the test can then withdraw the capsule, and the capsule will sample cells along the way. So samples from these devices are then used to assess for biomarkers that are associated with Barrett's. So in the case of Cytosponge, they perform immunohistochemical staining for trefoil factor 3, which is known to be associated with Barrett's. EsophaCap uses PCR to look at a methylated DNA marker panel, and then EsoCheck is looking at a 2 biomarker assay. So the pros of this, as you can probably sense, is that you can do this in the clinic setting. You don't need sedation. It's very safe. There are really not that many adverse events reported, only like rare cases of capsule detachment requiring endoscopy. And so we actually have a decent amount of experience, predominantly with Cytosponge. The performance metrics cited for this in terms of Barrett's detection have been a sensitivity of 76 to 80%, or specificity ranging from 77 to 92%. So, fairly good metrics for a screening test. And there's even been a randomized control trial looking at Cytosponge. So the BEST-3 trial, which was published last year, looked at primary care settings in the United Kingdom. They randomized 13,000 patients with chronic GERD, either to be invited to receive the Cytosponge or to undergo usual care, which was no screening at all. And for their primary outcome, in terms of Barrett's diagnosis, they found Barrett's in 2% of the Cytosponge arm compared to only 0.2% in the usual care arm. So that was a 10-fold increase in actual Barrett's detection. And on top of that, 9 patients in the Cytosponge arm were found to either have dysplasia or early cancer that could actually be intervened on. So definitely, this is an exciting new tool to have in our arsenal to potentially actually improve our catchment of Barrett's patients who are at risk. Something to note, though, was that in those invited to participate, only 39% actually ended up getting the Cytosponge. And so, thinking about ways to really implement this in real-world practice will take some work. So looking forward to the developments in the future. The next technology I'll briefly describe are volatile organic compounds, VOCs. These are kind of still in the works, but I think kind of interesting. These are metabolic end products that are detected in exhaled breath. And there's been the development of the ESA-nose, which is basically an electronic nose that has an array of sensors that interact with VOCs to create an electronic profile. The device has a machine learning platform that trains the nose to recognize certain diseases like Barrett's. And so a preliminary study done in the Netherlands found a sensitivity of 91% and a specificity of 74% for diagnosing Barrett's when compared to the gold standard of endoscopy. And so where do we fall with the guidelines with all these non-endoscopic devices? For the first time in 2022, the ACG did put out a conditional recommendation that you can consider the non-endoscopic capsule device as an alternative to endoscopy for screening, and the AGA clinical practice update also put out a similar recommendation. So for the last part of my talk, I want to talk about some endoscopic technologies we have that can improve our ability to risk stratify Barrett's patients to predict who will go on to progress. So first, I'm going to go over Watts 3D. What Watts is basically an abrasive brush that is passed through your endoscope channel. It obtains cells kind of from deeper layers of the epithelium and can sample a wider area of the Barrett segment. The tissue specimen is then analyzed using a neural network that reconstructs the images into a 3D image and also flags areas that are high risk for IM or dysplasia. These high-risk areas are then passed on to a pathologist who performs manual microscopy. And so our current literature available for studying Watts has really been looking at Watts in conjunction with forceps biopsies. So certainly not a replacement for the Seattle protocol biopsies currently. And in a large meta-analysis looking at over 19,000 upper endoscopies, comparing Watts plus Seattle versus Seattle protocol alone. For the outcome of Barrett's detection, there was an absolute increase of 16% and a relative increase of 1.6%. And for the outcome of dysplasia detection, there was an absolute increase of 2% and a relative increase of 2%. And so just something to note with some of these studies, one significant limitation has been that the true sensitivity and specificity has been a bit difficult to assess because in some of the studies, the diagnosis of dysplasia on Watts has not been confirmed with upper endoscopy subsequently. So further studies kind of trying to validate that further would be helpful. But this is definitely an exciting new tool to have in our arsenal. And looking forward to potentially using this more. I know some of us have already used that here at Redwood City. The last technology that I want to go over is TissueCypher. So TissueCypher is a really exciting new tissue systems pathology test that you can perform on biopsy specimens from endoscopies that you're already obtaining for surveillance. It's performed using immunofluorescence biomarker labeling. And the way it works is it analyzes 15 features from 9 different biomarkers or nuclear morphology or tissue architecture to produce a score from 0 to 10 that is then categorized as a low, medium, or high risk. And what it puts out is the 5-year risk of progression to either high-grade dysplasia or esophageal adenocarcinoma. And so there have been multiple validation studies that have suggested quite good performance for the detection of progression. And in one of the larger multi-center analyses with patients, a couple hundred patients with either non-dysplastic Barrett's, Barrett's that has indefinite for dysplasia, or with low-grade dysplasia, they performed an adjusted analysis incorporating various known progressors or risk factors for progression to cancer, including expert diagnosis of low-grade dysplasia. And in this study, they found that high versus low TissueCypher risk score was independently predictive of progression to high-grade dysplasia or cancer with an adjusted hazard ratio of 6 and a confidence interval of 3 to 12. So, the study is really pointing to the fact that TissueCypher used in conjunction with our standard histologic assessment of dysplasia could be really useful for risk stratification. In terms of performance metrics, the current sensitivity has been estimated at about 30% for assessing the risk of progression. This improves to about 50% when you assess multiple levels of biopsies, but the specificity is quite high at 95%. And so given the low sensitivity, the ACG did perform the grade assessment to try to assess this technology for routine use and could not make a recommendation at this time. The AGA does state in their clinical practice update that you can consider using TissueCypher to help with risk stratification in non-dysplastic Barrett's patients. So what's my current approach to screening and diagnosis of Barrett's? So I will offer screening to patients based on the 2022 clinical practice updates who have at least 3 of these risk factors not requiring Barrett's or not requiring GERD as a prerequisite criteria. I will currently offer screening with upper endoscopy. And then, in patients who do not have Barrett's on their initial screening EGD, I would not offer a repeat EGD unless they develop symptoms. For patients who have either short segment Barrett's or maybe questionable findings on their initial endoscopy, I might consider using Watts 3D to help with either detection of Barrett's or potential risk stratification. And then for my patients who have non-dysplastic Barrett's, or certainly for those who are indefinite for dysplasia, I'd consider using TissueCypher as an additional risk stratification tool to help figure out maybe who will most benefit from closer surveillance, or even considering if we can spread out some surveillance intervals. So putting all this together, I think the future of Barrett screening is really exciting. From our general population, hopefully we'll have more risk prediction tools to identify at-risk populations that will then be able to deploy these non-endoscopic screening strategies in the primary care setting to really send to GI folks who are high risk that will most benefit from upper endoscopy. Using additional risk stratification algorithms, technologies like TissueCypher, hopefully we'll be able to identify the highest risk population who will most benefit from surveillance and treatment, all with the goal of preventing esophageal adenocarcinoma. So thank you so much for your time, and I'd love to take questions at the end.
All right, we're going to continue moving down the GI tract into the stomach. We have a talk on gastric intestinal metaplasia from Dr. Robert Kwong. He's an instructor of medicine and advanced endoscopist. His research is supported by K Awards, and he is very talented. We're lucky to have him here.
All right, hi everybody. It's a pleasure to be here. Thanks to the course organizers for inviting me to talk today. And so today I'm going to be talking about gastric intestinal metaplasia surveillance, who and how often. First, I'm going to talk a little bit about the epidemiology of gastric intestinal metaplasia, or GIM. So GIM is a precursor to cancer. So it's along the pathway to cancer. And so we believe that it is a result of chronic inflammation following an inflammatory cascade known as Coria's cascade. So when there is inflammation of the stomach. The stomach mucosa progresses through a series of precursor lesions, beginning with non-atrophic gastritis, atrophy, intestinal metaplasia of various degrees of severity, followed by dysplasia, and then ultimately cancer. So worldwide, probably 90% of this is due to Helicobacter pylori, but in the United States, there's actually a fair amount of autoimmune gastritis as well. So speaking of autoimmune gastritis, how do we distinguish H. pylori gastritis from autoimmune gastritis? Well, one thing to look at is the location of the inflammation. So in H. pylori-induced gastritis, almost always the inflammation begins in the antrum or the incisura of the stomach. So that's the like the bottom section of the stomach here below this dashed line. And so over time, it might progress upward, but it always begins here. And by contrast, in autoimmune gastritis, the inflammation is always centered on the gastric corpus or body, and almost it rarely involves the antrum. You could have both H. pylori and autoimmune, in which case you could have inflammation in both locations. But that's a way to potentially tell if someone has autoimmune versus H. pylori. So what is the prevalence of H. pylori in the United States? We estimate this to be approximately 5%. This is based on patients who are undergoing gastric biopsies. In the general asymptomatic population, we don't know, but it's probably close to 5% as well. So risk factors for GIM are the same as risk factors for gastric cancer. So non-modifiable risk factors include Asian race, Black race, American Indian or Alaskan Native race, Hispanic ethnicity, male sex, family history, particularly first-degree relative with stomach cancer, increasing age, older birth years, so there's a cohort effect toward decreasing prevalence of metaplasia. And then modifiable risk factors include historical or current infection by H. pylori, current or prior smoking, and residence in regions with high H. pylori prevalence or high gastric cancer incidence. So I wanted to spend a couple of minutes talking about diagnosing GIM and endoscopic and histologic considerations. So Margaret had alluded to some of this as well. So the performance of high-quality endoscopic exams is critical. So adequate time should be allocated for mucosal cleaning and gas insufflation. There's data out of Asia that suggests that at least 7 minutes, so that's from when the endoscope enters the mouth to when it leaves the mouth, that improves quality in terms of detection of cancer, dysplasia, and metaplasia. Adequate photo documentation of all examined areas of the stomach, including antrum, incisura, body lesser, body greater, cardia, and fundus, has been recommended as a quality indicator. And use of high-resolution endoscopes with the ability to perform narrowband imaging is very important. So just to highlight this point, I just said that you should use the latest generation endoscope. This is certainly not it, but I wanted to include this picture on the left here because this is from Uedo's original 2006 paper in endoscopy, which described this characteristic finding in metaplasia of the light blue crest sign. And so often in metaplasia, you'll see these patchy bluish, whitish areas here along the lesser curve of the stomach. And so when you actually examine this up close with magnified NBI imaging, you'll see these patterns of blue lines, which was kind of termed the light blue crest sign. And so NBI is really helpful for detecting GIM, as can be seen by this repeated measures study where endoscopists were blinded, and then they repeated the exam, one with high definition white light and one with NBI. Your detection of GIM basically doubles with use of NBI. So use of NBI exam with latest generation endoscope is very important for detection. Here's just another example using a more modern endoscope showing that even with an HQ190 endoscope here kind of in this 2 o'clock region, you can see, maybe a little bit of something here, but it's really quite subtle if you're not looking for it. But when you apply the NBI filter, it becomes very apparent, the light blue crest sign here. And so this is almost always going to be intestinal metaplasia. In fact, it's so obvious that in large parts of Asia, they don't even bother to biopsy this anymore. They just say in the report, GIM. So Briefly, also the importance of kind of mapping biopsies. And so this is the Sydney Protocol here. And so Sydney Protocol refers to, there was this like meeting of pathologists they kind of determined the best way to biopsy the stomach, as well as to grade the biopsy specimens. And so usually 2 pieces are taken from the prepyloric region, one at the 3 o'clock region and one at the 12 o'clock region and one at the 6 o'clock region. And then 1 piece is taken from the incisura. And so I sometimes get asked the question, where does the incisura piece count? It counts as antrum, both for the stress stratification purpose, but also like biologically, the incisura is part of the antrum. And then we take a piece from the body along the lesser curve, and then a piece from the body along the greater curve. And so more and more now, pathologists in the United States are using this severity scoring system, which is also described in the Sydney system. And so roughly speaking, this is normal or none. If you have less than 30% of the glands involved with goblet cells, this is mild, 30 to 59% moderate, and then 60 or greater severe or marked metaplasia. And so the reason it's important to try to begin to adopt this system in the US is that we can use this to calculate what's called the OLGIM score, the operative link score for a gastrointestinal metaplasia. So you plug in your severity score from the antrum here, and then you plug in your severity score from the body here, and then you can kind of calculate OLGIM stage, which goes from 0, which is none, to 4, which is marked IM of the antrum and marked IM of the body. And so, as you'll see later, this is actually really important for risk stratification. Those appear to be stuck. Okay, and one other point is just incomplete versus complete features of the histology. The complete versus, so incomplete is a type of metaplasia which is a little bit more disorganized versus complete. So on the complete metaplasia here, you could see that, you know, the goblet cells are all kind of nice, evenly sized. It's like nice and regular brush border here, whereas in incomplete, you can see the goblet cells here are more variable in size. And so this is increased risk for cancer. Back in the day, they used to use these mucin stains to try to distinguish these. The mucin stains are no longer used anymore because they're carcinogenic. Okay, and so now let's talk about the risk stratification and the management of intestinal metaplasia. So the first thing is just remember H. pylori testing, H. pylori eradication. So first, all professional societies recommend that we eradicate H. pylori for any reason. So if it's detected for any reason, it should be eradicated. So it goes without saying, if you have intestinal metaplasia, that H. pylori should be eradicated. H. pylori eradication decreases the risk of cancer incidence and cancer mortality in the general population, and it probably decreases the incidence and mortality of cancer in individuals with GIM. We just don't have that gold standard data yet. But even after H. pylori eradication, patients with GIM remain at elevated risk for cancer. So the overall incidence of gastric cancer in GIM is about 0.1 to 0.2%. The more we learn and as the more data we get, this number keeps dropping. Very similar to Barrett's. At the very beginning, they thought that the incidence of cancer in Barrett's was like 0.5% or something like that. And then every year, as more and more low-risk Barrett's was being diagnosed, this number kept dropping as the denominator got bigger. So same with GIM. As we diagnose more low-risk GIM, the denominator gets bigger, but the cancer numerator stays the same. The incidence is decreasing. So probably it's about 0.1% in the West. So what are ways that we can risk stratify? So we use both individual level factors as well as tissue level factors. So it seems that at the individual level, family history is quite important. So having a first degree relative with gastric cancer increases your risk for cancer by about 4 to 5-fold. So that's a pretty large increase in risk there. At the tissue level, the extent as well as the histologic severity of the GIM is very important. So cohort studies have suggested that extensive, which is defined as both antrum and body involvement of GIM, is at least 2-fold increased risk for cancer relative to antrum only. And I actually think that number here, this is data from the AGA technical review, is probably too too conservative. It's probably even larger than that. And so I talked about the importance of for us to kind of start using OLGIM stages for this. And so case control studies suggest that, high OLGIM 3 and 4 is associated with at least a twofold risk. But recently last year, this cohort study was published based on a high-risk Chinese-Singaporean cohort. And they actually found that OLGIM stages 3 and 4 were associated with a 25-fold increase in risk of cancer relative to an OLGIM 1. I think there's more data to suggest that this is probably more accurate than the two here. So this is a big difference, a 25-fold increase in risk relative to low stages. So this is why it's important for us to really establish the extent of the metaplasia and ideally establish the severity of the metaplasia. We're just in the very early stages of GIM relative to Barrett's. This is our PROG classification in GIM. And so just like you wouldn't treat someone with C0M1 Barrett's the same as someone with C8M10 Barrett's, you wouldn't treat someone with an OLGIM of 1 the same as someone with an OLGIM of 4. And so as we get better data, as more and more centers in the United States start adopting these scoring systems, and as we begin to follow these protocols more and more, hopefully we can develop a more nuanced and precise approach to surveillance. Finally, the incomplete versus complete histology. As you might expect, incomplete histology, that more disorganized tissue phenotype, is associated with about a 3-fold increase in risk of progression relative to cancer. So these data are all important for the next slide, because now I want to talk about the US and European recommendations for surveillance. And there's a lot of text on this slide, so I'm not going to bore you and read through everything, but I just wanted to point your eye to 2 features. The first, these are the references if you wanted to actually read the guidelines yourself. But the first thing I wanted to mention is look at the years of these references: 2021, 2020, 2019, 2019, 2019. These are the European on the right and the American on the left. So this is all very new. The fact that there even is this slide here is a major paradigm shift. It's a major improvement, because before 2019, you might have chosen to survey your patient after a discussion, but it was not a normative opinion. Like, there was no proffered opinion by any professional society that you had to survey patients with metaplasia. It was kind of up to your clinical judgment. So for the first time in the West, there is now an official formal opinion by professional societies that we should be surveying patients with gastric precancerous lesions. And this is a paradigm shift. This is a major advance. And, it's 10 years behind Barrett's, about 20 years behind colon adenomas. But now, for the first time, we can say definitely we should be surveying patients with precancerous lesions. So this is a big shift. In general, the European and the American guidelines are more similar than they are dissimilar. In fact, they're really complementary. Both recommend a stratified approach to surveillance. So there's no guideline that says anybody with IM, regardless of their individual risks, regardless of the tissue extent, should undergo surveillance. So it's really a stratified approach to surveillance that uses both individual risk factors. So in the case of the American guidelines, family history and race, and Europeans, mostly family history, as well as the mucosal features, so the extent of the metaplasia, the severity, the OLGIM staging of the metaplasia, as well as the presence of HP persistence. Both sets of guidelines recommend that Sydney protocol biopsies should be used in order to adequately evaluate the topographic extent of the disease. And finally, GI pathologists with expertise should be used to interpret biopsies, both for histologic severity and to ascertain the incomplete phenotype. There are some subtle differences, though, between the American and the European guidelines. The American guidelines place a greater emphasis on race. They do not incorporate OLGIM and OLGA staging. The staging system was developed in Europe, so that hasn't kind of fully percolated yet into American centers. The American guidelines are much more loose, if you will. So there's a suggestion of 3 to 5 year intervals to emphasize shared decision-making, discussion of risks, how risks and benefits may change. So really kind of it's your decision within these intervals, whereas the European guidelines are much more structure. They say if you have family history and extensive IM, it's 1 year, and that's it. So much more kind of structured, in general, more conservative, the European guidelines, use of family history but not race, and then extensive use of the OLGIM and OLGA staging systems. So with my last slide, I just wanted to discuss a couple of remaining gaps in the literature. So these surveillance intervals that we talked about all are just based on expert opinion. So we need better stratified incidence data, especially from the West, to guide these surveillance intervals. Everything I talked about is for patients who are already diagnosed with metaplasia. We know that I said at the beginning about 5% of the population probably has metaplasia. That means probably like there are 10 times more people with metaplasia who are not diagnosed than are diagnosed metaplasia. So, who do we actually screen for GIM? And this is kind of completely unknown right now. And then finally, how do we improve awareness and detection of GIM among Western endoscopists? How can we increase use of NBI, Sydney system biopsies, and how can we communicate with our pathologists to start scoring biopsies using the Sydney protocol? And that's the end of my talk.
So for our next talk, we're going to talk about some of the racial and cultural barriers to screening. We have Dr. Arden Morris, who's a professor of surgery and the vice chair of clinical research. Very excited to have you come speak for us.
All right. Good afternoon. Thank you, David, and thank you to the organizers for inviting me to speak to you today. I have to tell you a couple of things to talk about racial and cultural barriers on gastrointestinal cancer screening. One thing is I'm a colorectal surgeon, and it occurred to me about a half an hour ago that gastrointestinal does not equal colorectal. This entire talk is all about colorectal cancer screening. I'll just tell you that right up front. So be ready. I have no financial conflicts related to this talk. First, I think it's important for us all to kind of have some common definitions. Our understanding of race, ethnicity, and culture has really become much more sophisticated, especially in the last few years, and I think we still, in our society, have a ways to go. But specifically what I'm meaning by race in this talk is taking the sociological definition, which means a group that is identified based on superficial physical characteristics that are deemed important by society. So that's race, okay? And I think that the key word in that entire definition is society. It really involves social interactions, and it involves social hierarchy, and what is perceived has an effect on social. We know that there's more genetic variation within races and between them, and we know that we don't even know how to define mixed race. I mean, which we all probably are, actually. So that's where I'm coming from. When I talk about ethnicity, this really refers to a group of people who have a shared culture. And what culture means usually, especially when researchers talk about it, is shared language, also shared traditions, values, and references. Usually, however, when researchers like me talk about something like culture, we have to get it down to something that we can measure, and oftentimes that will simply be language, as you'll see in a couple of the studies that I want to describe. So that's what we're talking about here today. And with that in mind, my objectives are to review evidence of the problem of barriers to colorectal cancer screening, and to describe some of the tested strategies for management. I have only pulled a few examples, but I think they're pretty nice examples. And then lastly, to discuss implications and potential opportunities. So first of all, I'm not going to talk too long about the evidence of the problem, because if you've opened a clinical journal in the last 10 years and looked at the table of contents, you probably have a sense that the evidence is simply overwhelming. There is a mountain of descriptive evidence, and I don't think you guys need to hear that. Instead, what I'd like to talk about is specifically focusing on screenable cancers. And as a surgeon and a health services researcher, I think about screenable as being lung, colorectal, prostate, breast, and cervical. And of course, we're going to cone in on colorectal here. But if you look at the top two figures, these are all sites on the left, on your left side. So that's really, if you were the screen, it would be on the right side. If you're the patient being the screen, it would be on the right side. So on your left side is the male, on the right side is the female. Let me see if I can use the pointer here. Yes, male and female. You see that the red bar is non-Hispanic Black mortality rate from screenable cancers. The blue bar is non-Hispanic White mortality rate from cancers, screenable cancers. And on a positive note, all of these mortality rates are going down over over time. We're doing better and better. So yay us, we are actually doing better. This looks good. When we look at the mortality rate ratio, this is really a marker for the relative mortality among Black people versus white people with these cancers. So a decline in the rate ratio is good. It means that the disparity is going down. And relative disparity basically is sort of a sign of discrimination, okay, instead of absolute disparity. So now I'm going to just take us to colorectal, and you see that as a contrast to many of the other cancers in colorectal, well, first of all, in a good way, all of the mortality rates are going down. This is largely due to screening. I think this room in particular is intensely aware of that and the incredible importance of screening and the uniqueness of colorectal cancer screening, which is also preventive. Like, you really don't get that anywhere else. It's wonderful. However, the mortality rate ratio is actually going up, and it's particularly bad among men, and we're talking about Black men. So less screening and then less high-quality treatment, or just omission of treatment altogether in many different ways. For Black men, it's really sort of there's a bell ringing that we need to listen to. The good news is that screening works, and this is from the same group as the last graphs that I showed. This is the group in Atlanta that basically curates the SEER data and provides these analytic reports every year, which are incredibly valuable for us to know across the nation what's happening with cancers. So you see on the left side is men, right side is women. The red bar is the anticipated colorectal cancer deaths if the curve had continued as it was, and we see that the black vertical bars are basically that area is the deaths averted. So really going very well in that way. But the bad news is that screening rates continue to be lowest among racial and ethnic minoritized communities. And I'm a little bit concerned about time, so I won't go too far into my definitions here, but happy to talk about it afterward if you want. Basically, the orange bar is non-Hispanic whites. Screening rates are the best among this group. We all know this. But for the other groups, they're ticking up with time, and this is actually very good news, except for Asian Pacific Islander. And that has pertinence to us in the Bay Area and the surrounding community. This is the most racially and ethnically diverse place I have ever been. I've been all over the country. This is an incredible place, and I'm really quite impressed by the large number of different cultural groups that live together relatively well here. This seems to be mostly attributable to language differences in the Asian and Pacific Islander communities. I'm going to talk a little bit more about that, but we're going to switch gears to strategies for management now. So away from the descriptive data and into what's being done to try to intervene. In order to create an intervention, you really need to have targets. And to have appropriate targets, you need to start with a theoretical framework or conceptual model to make sure that these things really do seem to fit together and what you're selecting to intervene on and spend lots of money and time and effort on is worthwhile. This is a common model. I had anticipated talking about it a little bit more, but somehow I'm going more slowly here than when I practiced this talk. So what I'd like to say about the Anderson model, a very famous model of equity and access to healthcare, is mostly that it's focused on the patient's experience, what the patients have experienced and perceive in their relationships with their providers and in the healthcare system and also the community. It does incorporate, so it's really patient-focused. It does incorporate aspects of providers, of the healthcare system, and of the community at large that surrounds everybody, but it's very patient-focused. And I think one of the I strongly believe, based on what I've read and done, that one of the reasons that the disparities persist so aggravatingly is that many of our interventions are focused on the patients. Let's teach the patients better. Let's make the patients trust us better. Let's change the patients. The patients need to change so that they come into the system and start complying with our ideal plan for what should happen here. And I think that researchers and clinicians are starting to see that it's really not working. It may work a little bit, but it's hard to sustain. What we need is multi-pronged approaches. This actually is a very nice study, and I've provided the reference here, using this particular version of the Anderson model to look at Hispanic and Asian American uptake of screening and completeness of screening. And they found that they were being underscreened. The uptake was low, both due to language issues in both communities and then also to trust issues within the Hispanic community. There was a substantial distrust of providers in the healthcare system, whereas in the Asian Pacific Islander community, that simply wasn't so. So different reasons for different ethnic communities. This is a more sophisticated model, also with more tangible targets to approach. I'm not going to talk a lot about this model either, but this was advanced by Drs. Carruthers and Dubany, and it's really a very useful model for thinking about the comprehensive problem and how to take a multi-pronged approach to it. It still incorporates patients and providers within the healthcare system and also within the community and the different touch points in all of these ways. And I'll refer to that a little bit more, although I'm not going to spend much more time on this model. Again, happy to talk about it afterward. So let's talk about a couple of studies. This was a study that was attacking the, I'll just go backward for a second and use my pointer, the touch points between patients within the healthcare system. And this could actually have a vertical bar that also says healthcare system. This could have a vertical bar over here that also says community. But in the interest of having a slide that you can actually look at, I didn't add that. So this was looking at culturally sensitive outreach and education. Again, very patient-focused. It was looking at patient navigators for colonoscopy completion and providing bilingual patient navigators to ensure that patients got their colonoscopies completed. They had multiple touch points with these navigators, multiple telephone calls. It was all telephone-based. And you can see in the data here that it was the language that was the issue with non-Hispanic whites, no movement on the needle for uptake of screening. Non-Hispanic blacks, they appear to have improved screening, an odds ratio of 1.39, but not statistically significant. But then if you look at the next bar down, the Hispanic population, we see that there is a major uptake in completion of colonoscopy with the provision of Spanish-speaking navigators, odds ratio of 2.6 compared to without, and that is statistically significant. So this was a nice start from this group, and it's something that John Carruthers really promotes, patient navigation. However, we also know that we need to go big, and we talked about that a couple of minutes ago. This is a nice study from Shivan Mehta at University of Pennsylvania. He's done some really interesting work in the community, really using principles of population health management and also behavioral economics to try to incentivize patients, reach patients, educate, and also interact with providers, clinics, and the community. And all of these boxes refer to different versions of colorectal cancer screening, but I'd like to direct your attention to the, I'm not loving this pointer, but to the upper left, any colorectal cancer screening. Each different colored bar is a different race or ethnicity. You see that with implementation of uniform access, no cost, making it as easy as possible for patients to access some screening strategy, that all of the bars went up. It was fantastic. It had a great population effect. However, there was no change in the disparities. So it was like all of the boats got raised, but the inequity stayed the same. And in some groups, it actually increased. It was a really important learning point that uniform access is not the only answer. It's part of the answer, but it's not going to be an adequate answer. So this is the last study I'll talk about. You can see it's pretty complex. There are a lot of luminaries in the colorectal oncology research world who are engaged in this particular study, which just launched. It's a randomized controlled trial of implementation, and they have multiple interventions across the whole spectrum of patient-physician system interaction and community. So a whole system of interventions that they're deploying. This is a complex study. It has a stepped wedge design because they're trying to control for a bias that would occur from secular changes. We know that things are getting better, so normal, that's just happening, and we can't say before or after because maybe that would happen anyway. Also, it helps to control for stepped wedge trial design, which I'm also happy to talk about later. Controls for contamination, meaning that those who have adopted the intervention won't have an opportunity to contaminate those who have not yet adopted it. So this will be really interesting. Keep your eyes open for this one. I think it's going to be interesting to see what happens with it. Hopefully, we will be able to distinguish noise from signal from noise in this complex trial where there are multiple interventions underway. So I just want to wrap up with some discussion of implications and opportunities from some of these things. And this I took from a paper by John Carruthers at University of Michigan. the chair of medicine there. He spent a lot of time thinking about this, and I had the opportunity and the good fortune to work with him. I was at University of Michigan for about a decade and a half before I got to Stanford. He had recommendations, and these are not certainly unique to Carruthers, but I think it's nicely displayed. In terms of research, which is, I spend a lot of time thinking about, we have some very straightforward things. Looking at the biological and environmental determinants, we see that age is going younger. I have a phenomenal number of very young Hispanic patients with advanced colorectal cancer. It's awful. I'm amazed. There's something going on biologically and environmentally that we need to understand better. And then also in that bottom left square, redesigning prevention, drug, and treatment clinical trials to acknowledge and address colorectal cancer disparities. And this really means racial and ethnic disparities in colorectal cancer outcomes. And I strongly believe that clinical trials going forward should always contain some component of data to be able to look at least what is happening among racial and ethnic minoritized patients in the trial, and also to recruit appropriately. Second column here is clinical, and I suspect that a lot of the group here in this room is very interested in what we can do clinically. Of course, we have some different types of tools that already exist. Stanford, in particular, has a phenomenal interpreter program, although I can't seem to get a Tagalog interpreter for any of my patient interactions. I don't understand that. Nonetheless, it's a great system. We have lots of different apps and other systems we can use. And then as well, patient navigation. It's expensive, but it seems to really pay off. I think that there's more to find out about that. And then to lower financial and insurance barriers to non-invasive screening utilization. This is the least expensive as long as there's appropriate follow-up for screen-positive patients with colonoscopy. And then this is really already happening in a very robust way, I would say, in the United States to assess what is the population incidence by age and race ethnicity. In terms of education, we all have implicit biases. One of them you just had access to for me was that when I read gastrointestinal, my implicit bias was that could only mean the colon and the rectum. We have other kinds of implicit biases too. This is real. We just need to acknowledge it and do our best with it, and I think stay open-minded and try to get better. Patient education shouldn't be the only thing that is done, but it certainly has a place in improving disparities, and engaging the community is going to be absolutely mandatory. So I'd just like to share some final thoughts, and I think that this was well spoken by John Carruthers. The great equalizer appears to be prevention. In colorectal cancer, I really do think it's all about prevention, screening, and getting the screening done. There's evidence that navigated colonoscopic screening can eliminate colorectal cancer incidence and mortality disparity in a disadvantaged subpopulation, as well as further reduce it for the majority population. So in health services research, we often talk about, are we going to narrow the gap, or are we going to try to raise all boats? What are we going to try to do? I think in the case of screening, we can have both. I think that this is possible for both with colorectal cancer. And I'd like to just conclude with that. Thank you for your time.
We're going to keep these moving. We have Dr. Walter Park, who's a virulent expert in this area, to talk about an approach to pancreatic cysts.
Okay, forward. Okay, forward. Okay, great. Well, thank you, David, and thank you to the organizers for inviting me to give this talk. I'm going to try to keep this pretty simple and rudimentary about the approach to pancreatic cysts. I'm going to just define the most common cyst types. We're going to review the current guidelines, and I'm going to talk a little bit about the current use of pancreatic cyst fluid tests. Now, while there's over 20 plus histological cyst type variants you could find in a pathology book, I'm going to focus on the three that we most commonly encounter now with increasing use of MRs and CTs and their higher resolution. And that's primarily the IPMN, or intraductal papillary mucinous neoplasm. I realize that's a mouthful. The mucinous cystic neoplasm and the serocystic neoplasm. Historically, we used to think the pseudocyst was the most common pancreatic cyst or pseudocyst, but with this change in our practice and the increased use of CTs and MRIs, it basically flip-flopped, such that pseudocysts are less common, and these IPMNs, mucinous cystic neoplasms, and serocystic neoplasms are more common than we thought. In terms of the overall prevalence in the population, we think it varies based on the image, on the quality of the image, the timing of the image, but it varies from anywhere from 2% to as high as 40 to 50% on some case series. I tend to believe more somewhere in the range of 2 to 5% in the overall prevalence. It does increase by age, so by the 8th decade of life, about 15% of asymptomatic individuals will harbor one of these perhaps precancerous cysts, most commonly the IPMN. So this is just a simple graphic that breaks down the IPMN. It's a precancerous by biology cystic lesion that hypothetically and biologically we worry that can transition to cancer. The most common variant is a side branch. To the anatomy, this is, to recall, the pancreas is a gland. It has a ductal system, and it's made of side branches and the main duct, which channels the pancreatic juice into the small intestine. And so the side branches really are the focal dilations of cysts, whereas the main duct involves anything of the main duct variant. And essentially what you're witnessing essentially is transformation of the cells at the ductal level, where the phenotype is a secretion of viscous mucin, which therefore likely causes the cystic kind of morphological appearance on MR or CT or seen by EUS. Below here are some examples of MR and CT as well as EUS features that are classical hallmarks of the branch duct or the main duct variant. Mucinous cystic neoplasms have a very unique demographic epidemiological presentation that they tend to happen in middle-aged females. Approximately 95% of those with mucinous cysts will be females, and they tend to affect the distal pancreas, the body or the tail, and under histology, which we wouldn't necessarily get during clinical evaluation, is the subepithelial stroma is made of an ovarian type stroma. It's thought and hypothesized, therefore, that with these demographic clues, that perhaps these are the reason why we see these, similar to what we see as pancreatic rests in the stomach, that this may be an ovarian rest that then finds its way into the pancreas as an explanation for why there's a huge predominance in the female population. Serous cystic neoplasms are clinically important in the sense that they're not precancerous, so we're not really worried about their progression to cancer. And so if properly identified, diagnosed with confidence, then no further surveillance or intervention is necessary. And for a long time, we didn't really have the tools to be able to recognize or make that diagnosis. So even though we may have a clinical or pretest probability that we were dealing with a serous cystic neoplasm, nevertheless, for lack of 100% confidence, we're often following these patients and using healthcare resources, as well as contributing to more patient anxiety. But here you can see they have the classical kind of microscopic honeycombing kind of appearance that you might see on CT or MRI. Histologically, they have a cuboidal cellular epithelial wall pattern that's glycogen secreting. And again, if they have these features, then you don't necessarily need to resect these or worry about them. So these are perhaps examples of cases that didn't need to be operated on. Now, the one caveat is some of these cysts will grow, even though they aren't of malignant concern. They can grow to a point of causing a mass effect. So therefore, resection is inappropriate for the purposes of palliation. So the point of this slide is just to show that in the past decade there have been numerous guidelines which perhaps reflects the increasing concern and anxiety both by our patients as well as our provider community as to what to do with these and as an attempt to try to standardize our approach. They're more similar than dissimilar in the sense that they all propose a relatively non-invasive approach for most of these cysts, and they're fairly standard in part because imaging like MR or CT is fairly standardized and reproducible, and they're fairly routinely used in all clinical practices such that you're not relying on high-volume tertiary care practices. This is something that you could potentially do in the community. So these guidelines all share a non-invasive imaging approach, predominantly leaning on MRI versus CT. MRI, the benefits primarily are that it's non-invasive, there's no associated radiation, and that there are standardized protocols to minimize inter- and intra-observer variability. The T2 imaging provides high resolution to identify cysts as well as its connection or lack of connection to the main duct or the side branches. The T1 imaging with good soft tissue contrast can also identify mural nodules, and it has sensitivity of 90% and a specificity of 7% for IPMN cancers. Some of the limitations, however, is it's still the detection of small or microscopic lesions that theoretically is where high-grade dysplasia or early cancers evolve, the sensitivity and specificity is less. MRI still are relatively expensive imaging modalities, and many patients need some type of Versed or Ativan to tolerate due to the claustrophobic aspect of MRIs, as well as the duration of 30 to 45 minutes. What are we looking for? So we're looking for a variety of different morphological imaging features currently as our state of the art. We're looking for cysts that have a greater than 3 centimeter size. There's nothing really magical about 3 centimeters. It's really just a binary arbitrary distinction, but really it's a continuum that with greater size, there's a greater association for cancer progression. We're looking for enhancing mural nodules within the cyst walls, thickened or enhanced cyst walls, a main duct that shows dilation somewhere between 5 to 9 millimeters. Again, this is a continuous variable. The more dilated it is, the more concerned you're going to be. You're looking for any abrupt changes, associated lymphadenopathy. Interestingly, increased serum CA19-9 is used, and that implies that you're actually using it, which is perhaps a more common practice, not so much in the West, because we don't necessarily advise or recommend CA19-9 as part of our screening. As well as these images and these guidelines propose serial imaging every 1 to 2 years, we're also seeing over dynamic changes that should a cyst show growth, that's also a sign of concern. So the point, we don't have time to go through all the guidelines, and I'm not going to do that. I'm just going to kind of highlight the main points. But this is an example. The Revised International Consensus Guidelines, the International Consensus Group was probably the first group to come up with consensus guidelines in the early 2000s, and specifically using the word consensus because the evidence at the time was all very low quality, so it was really expert guided. But it has evolved. There's been 3 different iterations since then. And the basic idea is if you have certain clinical or imaging morphologies, then if you're a surgical candidate, then you go to surgery. If you don't, then you get an endoscopic ultrasound for further risk stratification. And then if there's no evidence of high-grade dysplasia or early cancer, then you get kind of channeled into this surveillance approach based on cyst size. It works. Over time, it's been evaluated. But if you think about it from a precision medicine perspective, it's fairly rudimentary. We're relying on macroscopic kind of imaging features to guide this. But for the most part, it seems to keep us safe. And if anything, the issue is we're still operating on patients who probably didn't need to be operated on yet because they have low or moderate grade dysplasia, which actually doesn't exist anymore. The AGA guidelines I'm only highlighting this because they came out in 2015. Definitely a little bit more provocative than the prior guidelines in the sense that they made a proposal that some of these cysts are so low risk that you could potentially stop surveillance after 5 years. And that was, despite having done a fairly exhaustive technical review, it's a little unclear to what extent they could truly support that. Understandable from a population perspective given the low risk of transformation. And then the American College of Gastroenterology kind of fits somewhere in between from the detail-oriented of the international consensus to a more simplified version of the AGA to one where the ACG tries to kind of balance the both. But you can see similarities where you're really using risk stratification based on imaging, followed by endoscopic ultrasound, followed by size-based kind of surveillance approach. With the understanding that surveillance should not be pursued for patients who are probably surgically inappropriate due to other comorbidities or frailty. So once you move beyond non-invasive surveillance and you do show signs or have a cyst that might have more advanced features, endoscopic ultrasound is recommended for further risk stratification. Why? The benefits of endoscopic ultrasound include high sensitivity for diagnosing malignant-related mural nodules. There's no associated radiation. There are FNA capabilities, and this allows us to aspirate the cyst fluid for cyst fluid biomarker evaluation. And more recently, it's become an exciting platform for potential therapeutics or other diagnostic modalities vis-a-vis jumbo biopsies or confocal laser evaluation. Limitations, it's still relatively invasive compared to an MRI. There is some inter-observer variability among endosonographers between what they see, and it still is relatively expensive. So I'm going to talk briefly about what are the current biomarkers that we have available in routine care today. My talk's not really going to focus on what's on the horizon at this point. Cytology has historically been the go-to test for aspiration of cyst fluid, and historically it's been quite disappointing. Not too hard to imagine that when you're aspirating the cyst fluid, you're getting a very small amount of cyst fluid, and what you're hoping to find is shedded cells from the cellular wall, and essentially you're not getting enough cells, so oftentimes the most common report finding is paucicellular or acellular cyst fluid, non-diagnostic material. And so historically, the sensitivity and specificity for diagnosing a precancer cyst was relatively low. I think what has happened over time is a change in the way the cytologists have approached this, and that they've kind of lowered. They said to themselves, if we set such a high bar, we're not really making ourselves useful. So they reframed some of the criteria and created a system of high-grade atypia, which, when generalized and practiced among different pathologists, you can get a more improved sensitivity and specificity. Admittedly, I was a little skeptical to what extent that would disseminate across the country, and several years later, sure enough, my own pathologists are including it in their report now, so it seems to be happening. CEA is perhaps the oldest biomarker that we have, has been used for over 2 decades, and it has been very well studied, and it does seem to help discriminate precancerous versus non-precancerous. Its primary limitation, however, it does not tell us whether we're dealing with a higher grade dysplastic cyst. So its utility is relatively, for a while, it was the only thing we had, and so therefore it was really being used. I would submit to you today that while you can still order it, I'm not so sure you really need to order it. I think the new kind of test that that is clinically available now is really next generation sequencing DNA, and what we're doing now and what you can do is, with the presence of a KRAS or a GNAS mutation, 90% of pancreas cancers have KRAS, you can essentially diagnose with near certainty the presence of a precancerous cyst. So essentially you're doing what CEA could do. And then with further mutation analysis, including P53, PIK3CA, or PTEN mutations, you're really starting to be able to tease out which cysts microscopically might be harboring high-grade dysplasia or early advanced cancer. And this particular panel now even adds a CEA if you really wish. So another reason from a practical perspective, you don't really need to order CEA, but I don't think you necessarily need to, because this is giving us the information you really need. This has caught on in terms of, and this was somewhat done from our group, but we were looking for biomarkers, and through a metabolomic analysis, we identified something as simple as glucose as a discriminating factor, and it appears that glucose actually works just as well as CEA. Glucose, unfortunately, doesn't really differentiate high-grade dysplasia or early cancer, but it performs as well as CEA in terms of differentiating precancers versus non-cancer. So even if you weren't crazy about CEA, you could even just use glucose, and we looked at it using a glucometer at the bedside, and it seemed to perform just as well. So another reason why you don't really need to spend $150 or $200 for a CEA test when you could probably just use a glucometer. Now, technically speaking, we studied it in 3 different ways. We used a dipstick, a glucometer, as well as we sent it to the lab. The lab would prefer you send it to them from a quality control perspective, but even if you were to just do it at the bedside because you were a resource-limited environment, it seems to still work. So, what we have today really is cytology. Yes, CEA is still available. I think next-generation sequencing DNA mutation analysis is really the way to go. And glucose if you're in a resource-limited setting or you want an answer pretty quickly, at least to kind of risk stratify a patient. I really think DNA, in terms of if I had only so much fluid, I prioritize the DNA first, followed by cytology second, in terms of how I usually send off my fluid analysis. So pancreatic cysts are common and have caused a lot of anxiety for our patients as well as for our providers. Surveillance remains a preferred strategy, as most of these, although harboring premalignant potential, are fairly indolent in their time course and transition, very similar to what we've heard earlier today with Barrett's and gastric intestinal metaplasia, even colon polyps. Most of the polyps probably are indolent, but because we're there and we're removing them and it's safe, we often just remove them. Endoscopic ultrasound is used for risk stratification and for cyst fluid analysis. I'm a big fan of it. Granted, I have a bias in that I am an endosonographer, so full disclosure in that regard, but I think it's functioning as a platform for potential therapeutic studies such as ablation, as well as just the thought process that if you're really trying to do precision medicine and you really want to understand what's happening in the biology, cis fluid biomarkers are probably going to give that to us probably sooner than imaging. Now, we'll have to wait and see what artificial intelligence and radiomics may do to kind of guide some of the, or improve some of the lack of sensitivity for imaging in that regard, but perhaps in combination, we'll have a winning formula. Thank you.
I'd like to invite Dr. Shai Friedland to give us a primer on the perfect polypectomy, my favorite title from today.
All right. Well, thank you, David, and thank you very much to all the organizers and everyone here for coming. We'll try to do this talk in negative 5 minutes to get us back on schedule. So rather than talking about the perfect polypectomy, which I was hoping to kind of give you an update on what's new this year and last year in the field of colon polyp resection. And really it comes down to two major things, cold snare and ESD. So cold snare, we now have data that it's very safe and effective for polyps, not just under 10 millimeters, but for 10 to 19 millimeters for non-pedunculated polyps. It's also very safe and effective to use on serrated lesions that don't have dysplasia, especially of any size. And then if you're not in that category and you have a non-pedunculated polyp that's over 20 millimeters, the new kid on the block is ESD, submucosal dissection. And that leaves us with what about traditional snare piecemeal resection of larger polyps? And I'm going to try to argue that that's been squeezed out. But we do have a lot of patients that underwent that, and they're going to need careful follow-up because they can have recurrences for many, many years after their procedures. So non-pedunculated adenomas. Cold snare, we already know, is preferred for polyps under 10 millimeters. If they're very, very small, like 3 millimeters or less, you can use a forceps to remove them. But other than that, cold snare works very well. But in 2023, we have data now that demonstrates high efficacy and safety for larger ones, for 10 to 19 millimeters polyps that are not pedunculated. The caveat is in all of these studies, and I'm going to emphasize that again and again, is that you need to examine the polyp very carefully to make sure that there are no features that are suggestive of cancer. It's not an appropriate treatment for polyps that have a high risk of cancer in them. So we'll go over some of the criteria for that. Cold snare can be done with or without submucosal injection. It's typically in multiple pieces when the lesion is 10 millimeters or larger. Sometimes you get lucky, you might get it all, but typically it's in multiple pieces. And it's extremely safe. There's a very low risk of bleeding. You don't need to clip these wounds closed. And there may be a little bit of pain, especially if you inject epinephrine to lift the lesion. But generally, patients do very, very well. They can be sent home right afterwards, and you don't really have to worry about what's going to happen to them. So what to watch out for before you go cold snaring these large lesions? Well, you want to assess what is the chance that this lesion has cancer in it. And the first thing you look at is the morphology. So on the top left, we have, if this works, yeah. So this is a homogeneous, it's kind of all lumpy bumpy, but it all kind of looks the same. So these lumpy bumpy polyps, homogeneous, have a very low risk of having invasive cancer in it. On the other hand, if this lumpy bumpy polyp has a big lump, that's like, for example, 10 millimeter lump, and then all the rest are little tiny lumpy bumpies, that has a pretty high risk of having cancer in it. So that's not a good lesion to remove in multiple pieces with a cold snare. If it is not lumpy bumpy, and it's homogeneous or non-granular appearance, then it actually has a pretty high risk of having cancer in it also. So these are lesions to watch out for. They're also much harder in general to snare than the lumpy bumpy lesions. And then the worst actors are the ones that have a depression in there. So this is a non-granular. It doesn't have little lumps and bumps like that one, and it has an area in the center that's depressed. So these are all kind of warning signs that maybe you should attack this polyp in a different way. The other strategy to use to look at it is enhanced imaging, for example, narrowband imaging, if you happen to use the Olympus brand. This is a pattern, this JNET pattern of 1 is typical for hyperplastic polyps or serrated polyps without dysplasia. And so this, if you see that and it's a large polyp, then it's serrated, and you can go ahead and use piecemeal cold snare. This is a typical adenoma, JNET 2A pattern. So it looks like a brain, but it's all sort of uniform. It doesn't have any worrisome features, so that has a pretty low risk of having cancer. And then if you're going to do something in pieces, that's a good lesion. Once you start getting into this, something like this, where the vessels are variable caliber and they're sort of irregular, this has a high risk of having high-grade dysplasia or early cancer in it. And so again, this is not a good lesion to remove in multiple pieces with a cold snare. They're uncommon, so the vast majority are not going to have this. And then if you see this kind of thing, this is very amorphous. There's very large, thick vessels in it when you look up close at it. So this is cancer. It probably shouldn't be removed endoscopically because it's probably a deeply invasive cancer, and so the patient will need surgery. So now that we've looked at the polyp carefully, it's maybe 10 to 19 millimeters. It looks like an adenoma with a low chance of cancer in it. Well, what to do? If you want to have a stress-free kind of removal, take it out with a cold snare. You can take it in multiple pieces. This is a very nice study from 7 Australian centers, very well done prospectively. They actually got guidance from the IRB, and they said it's just not reasonable, not maybe to do a randomization. You might as well just compare it to historical controls in this, and that's what they did. But they did follow the patients very carefully. They had 295 patients and 350 polyps. The median size was 15 millimeters. So what did they exclude? Pedunculated polyps don't cut well with a cold snare, so they don't do that. And you can remove them in one piece with a regular traditional snare, so that's not good. But if it's non-pedunculated, if it doesn't have one big lump in it, like we said, the lumpy bumpy kind, but no big lumps, then that's okay. And if it doesn't have endoscopic features of malignancy, so that's basically those irregular vessels or something, ulceration or something like that. So those are the polyps that they took out. Most of the time they use submucosal injection. You can use it or not use it depending on your preference. The vast majority were removed in pieces. They were using cold snares. So these are very inexpensive cold snares. There's 3 manufacturers in the US that now distribute them. They're all good. And they purposely attempted to resect the polyps with a margin of normal tissue because it's so safe. You might as well make sure you get it all, remove a couple millimeters extra. It doesn't matter. Just takes an extra minute. And then because it was a study, they took biopsies of the margin and biopsies of the center to make sure it was all out. So here are 4 examples. On the left is a polyp. They injected it and then they removed it. And you can see that they removed it widely with a little bit of a margin. So lots of pieces with the cold snare. Very, very safe. Polyp number 2, polyp number 3, polyp number 4. They're showing you that they're basically doing a nice, careful job and really removing the polyp. But it's very easy to learn, very easy to teach, and very safe. And what did they find? Well, 350 polyps, 15 millimeter median size. Most of them were adenomas. A few had high-grade dysplasia. That's okay. They did well. About a quarter were sessile serrated lesions, and most of those did not have dysplasia, and a few of them had dysplasia, and they also did okay. Biopsies of the resections showed residual polyp in only 2%. So all these extra biopsies that they took for the study, only 1 out of 50 had positive biopsies. And then they did follow-up colonoscopies. They've done 2/3 of the patients have already had their follow-ups, and they found a recurrence rate of only 1.7%. Most of them did not have positive study biopsies, actually, so that's interesting. But very, very few adverse events, and you can tell that they were doing a meticulous job because they found every little tiny adverse event. So one bleed during the polypectomy that needed a clip, that's not considered really an adverse event by most people, but that just shows you that it's so easy and safe that you only needed to use a clip on one of these patients. A couple of patients had post-polypectomy syndrome, which we generally attribute to cautery, transmural cautery causing pain and fever and high white count. These patients didn't have cautery, so that's a little bit interesting. But it's sort of a pain syndrome with a little bit of inflammatory kind of features to it. And some patients had pain, and there were 3 minor delayed bleeds that actually all resolved with just observation. They didn't have to repeat the colonoscopy on any of them. So really an unbelievable safety record, and that just shows you that don't be scared of doing it, don't sweat. Don't worry about the patient going home, and don't waste your money on clips, and just take the polyp out. Works very, very well for this lesion type. There's another study that was done by Heiko Pohl and Doug Rex. This is kind of an odd study because they took 6 to 15 millimeter polyps and they randomized them to 4 groups: cold snare with submucosal injection, hot snare or traditional EMR hot snare with submucosal injection, and 3 different centers, although almost everybody was done at Indiana. They used dedicated cold snare. They injected some blue fluid in those patients that were getting injected. And immediately after the resection, they also biopsied the margins and the center of the polyp. And so the 6 to 9 millimeter polyps, that's not very interesting. We already know that cold snare is the way to go, but it's interesting that everybody had a complete resection. All these biopsies that were done to check the resection site were all negative. So the more interesting part is the 10 to 15 millimeter polyps. And in these, 7 out of 129 had residual on the biopsy. So that means the resection was incomplete. And which groups had the incomplete? Well, not the cold snare. Cold snare out of 27, all perfect. The cold snare with injection, there was just one of them was an incomplete resection. Hot snare, a few more, and then hot snare with injection. So traditional EMR had the most patients. These are all small numbers, but it's telling you that cold snare is really at least as good and much easier and safer. So that's it for 10 to 19 millimeters. We've got 2 more categories of polyps, sessile serrated lesions, which can be bigger than 2 centimeters. And most of these are not dysplastic, and we'll go through a little bit of how to tell when they're not dysplastic. If they don't have any concerning features, then you can do cold snare on them. And so that's our next study. So here we're back in Australia with Van Hatten et al. And this is a comparison of 20 millimeter or larger serrated lesions resected at 4 Australian centers. And this is again retrospective. What they did was they changed their policy in 2016. They went from traditional EMR to cold snare with injection in general. And so no more cautery. They basically turned off their cautery units in 2016 for these lesions. They excluded 12 lesions in the cold snare era that they had some worrisome features, so they decided to treat them by EMR. They should have probably treated them by ESD, now that we know. But anyway, they took care of them a different way. And so the non-worrisome lesions, they had a technical success of 100%, which was better than the old days a little bit, where they couldn't get all the old with EMR. The recurrence rate was 4% in both groups. So basically, it's doing as well as the traditional EMR. The difference is in the complications. So delayed bleeds, 5% for the old group. When you use cautery, 0% for cold snare. So no more delayed bleeding, which is nice. And muscle injury is a euphemism for small perforation. Arden is sitting there grimacing because that's who we used to call when we had muscle injuries. But now muscle injuries are usually treated endoscopically because they're small perforations that didn't go to surgery. That's basically the definition. If they went to surgery, they're a bad perforation. But there were none in the cold snare group and 2 or 3% in the hot snare. So it's safer and just as effective. So here's an example of a serrated polyp, and we're going to remove it with cold snare. And the nice thing is, if you know what can happen, the only bad things that happen is sometimes your snare slips and sometimes it gets stuck. And if it gets stuck, you unstuck, you just open it again and try again. And if it misses, you either change to a different shape of a snare or you just keep trying. And it's very nice for us to teach the fellows how to use the snare. They get lots of practice because it's going to be like 20 or 30 pieces. And you put a little blue in it so you can easily tell what's mucosa left behind and what's not, and it's pretty simple. There's another example, and the same thing. This one, I think the snare will slip off at the beginning. So that's, if you close it and it slips off, then you basically, in this case, we change brands to a different shape, and then it grabs it and you start cutting. And once you start cutting, it's pretty easy to keep going. So we try to encourage this technique. Okay, so there are some pitfalls with serrated lesions. The margins can be very subtle. So we often inject saline or with some blue in it, indigo carmine or methylene blue, and that sort of helps us to see the margin. Serrated polyps are often larger than you think. You could be looking at just a part of it, and then you realize halfway through that it's 5 centimeters actually, and maybe you didn't want to tackle this one today because you have a long schedule. So make sure before you start cutting, you look at the whole thing. Make sure you can reach all of it. Don't start cutting something that you can't cut the rest of it. And if you're going to abort, the best time to abort is before doing anything. The next best time is after you inject some saline. That's okay. It'll be a little harder next time, but not that much. But try to not cut half of it. Cut or don't cut. Either way is okay. Biopsies can cause some fibrosis and can make it a little bit harder. If you're going to biopsy it, just one biopsy is enough. We don't need 10 biopsies of this thing to make it all scarred. And then examine very carefully. That's the most important thing for evidence of dysplasia. What it'll look like is it'll be a serrated polyp, but then it'll have an area that looks like a regular polyp, like an adenoma, and that's a serrated polyp with dysplasia. So here's an example of a serrated polyp with dysplasia. So you can get confused and only see the part that looks ugly, but next to it is a large flat part that's also polyp. So all this stuff around it is serrated polyp, and then the lump is where the dysplasia is. And you'd want to get this out probably in a good way. In this case, I think ESD is the best way because there's no recurrence. And then you make sure that you know exactly what you got. This is another example. This is a serrated polyp, but it has this area here actually looks like an adenoma because that's the dysplastic part. And look next to it, it kind of progressively becomes smoother and smoother and more serrated looking in the areas around it. So that's another example of a serrated polyp with dysplasia. And again, was removed by ESD. We've talked about all this. So what about other things, other adenomas or dysplastic lesions that are larger than 20 millimeters? Well, I'm going to argue that the best treatment for those is to remove them in one piece, and the way to remove them in one piece is by ESD. That has a much lower recurrence rate, and as we'll see from the data on the next slide, people used to say there's not that many of these polyps are cancerous, so it doesn't matter how you remove them. Well, not that many are cancerous until you remove them in one piece and see what the pathologist says. So this was a randomized study in France, 11 endoscopists with 359 patients. They took lesions in the colon that were at least 25 millimeters. They excluded some that they thought it was unethical. They should just go directly to ESD to remove them in one piece. These are rectal lesions or depressed lesions, and so those they did not even include in the study because they said it would be unethical. But what they found was that the recurrence rate in the EMR group they were excellent EMR doctors, a very low recurrence rate of 5%. ESD is 1/10 of that, so almost nobody recurs in the ESD group. R0 resection, that means a one-piece resection with clear margins, 94% in ESD versus 12% in the traditional snare. Delayed bleeding is about the same. About 1% of the patients needed emergency surgery for complications of ESD. That's sort of par for the course, and it does take longer, so 70 minutes versus 110 minutes. But to me, we all knew that this was going to be true, that the recurrence rate on ESD is very, very minimal. But what was very interesting is to finally see was that the rate of superficial submucosal cancer, this should have been the same. These were randomized. It was 3.5% in the ESD group and 0.5% in the EMR group. What happens is, and we knew this was happening, but we couldn't really prove it, is that the pathologists are missing 6 out of 7 superficially invasive cancers when you send it to them in multiple pieces. So you are removing what you think might be an adenoma. The pathologist is telling you it's probably an adenoma and it was a cancer the whole time. And the problem is that these people sometimes come back a year or 2 or 3 years later with metastatic cancer. And so that's another reason to do ESD. So here's just one quick example. This is a patient that was treated at another VA 10 years ago. We had a flat polyp. Here it is under NBI. They did a standard resection with a snare. He came back. It recurred. Came back again. Another recurrence. Came back again. A third recurrence. Came back again. They start taking pictures from farther away. That's not how you look at, but they treated him a fourth recurrence, and then they finally, after 4 treatments, they said, it looks pretty okay, and follow him. The problem is you need to look more carefully at these EMR sites, and looking from far away is not enough. So you need to look with white light and with something like narrowband imaging, and then you need to look up close with near focus and look again with narrowband and near focus. This scar looks good. Nothing to be done. It looks perfect. This scar, on the other hand, as you get closer to it, you see that there's adenoma there. So this is a recurrence. Very nice to see with near focus when you're kind of magnified up close to it. But carefully looking at it, you'll also see it when you're quite close, just not from very far away because it's very flat. This is a study that was done to kind of look at which way of looking at it is best. And what I would highlight is if you're confident, you look at it and you're pretty sure what you're looking at, and you look with narrowband imaging and near focus, and you say that it looks good, then it's good. 100% sensitive for detecting recurrence. If you say it doesn't look good, then the specificity with white light is quite good. So about 98% of the time, that means it's going to be a recurrence. So here is this patient again after 3 more years, and it's still, if you look from far away, it still looks okay, but it's starting to look a little suspicious. And when you look closely, it's the whole scar is adenoma. Amazingly, it's still adenoma after 10 years. It's the exact same size as the adenoma was 10 years ago. It covers the exact same area. The only thing now is it's really, really fibrotic. It's really scarred down from 4 treatments. So now the way to treat it is by ESD, and unfortunately it's much more it's much more stressful because you're right on top of the muscle. It doesn't separate from the muscle, and you're kind of scraping it off the muscle and trying not to perforate too much. But it was an adenoma. It's the exact same size as the adenoma was 10 years ago, and luckily it wasn't cancer. But it could have been a cancer, and it could have been a metastatic cancer by this point. So the take-home message is, if you're worried about the lesion, look at it carefully. If you really want to remove it in one piece. But the most important thing really to keep in mind is to have a careful look at the lesion before you decide what treatment you want. And in 2023, after you look at it carefully and you see that it's a low-risk lesion, then cold snare is the way to go for up to 20 millimeters or even bigger if it's cell-serrated. On the follow-up exams, examine the post-resection scars up close and get really close and make sure that you can see the pattern on the surface, and then decide if you want to biopsy it or not. And then consider ESD for lesions with worrisome features or with fibrosis or above 2 centimeters with dysplasia. Thank you.
I'm not going to introduce myself. All right. So today we're going to talk about colon cancer screening. Not right now, but we're going to try and get a sense of what is colon cancer screening going to look like over the next 10 years. Don't hold me to this. So we'll talk about advances in colon cancer screening that we see, colonoscopy cancer screening that we do right now. Talk about some stool-based testing, blood testing, as well as some other options with capsules, imaging, and then I'm going to try and make predictions throughout. So first, we talk a lot about AI, but what does AI say about AI? So I was curious. So I asked ChatGPT, how can AI be used for colon cancer screening? And it actually wrote me a very nice essay. And I'm going to summarize a little bit. It actually broke it down nicely. Image analysis. So analyzing medical images for colonoscopy or virtual colonoscopy, detecting lesions that might be missed by human interpretation, decision support, doing the right thing for the right patient, as well as analyzing patient data to personalize care, risk assessment, so figuring out a patient's risk of developing colon cancer in ways that may not be readily available in the current clinical environment. Determining appropriate screening based on each individual's personalized risk, patient outreach. And these were ideas from the computer, which I thought was cool. But I thought I'd add a few more. So quality improvements in assurance can also be done in some ways better than with a person, because we all have our biases. And finding ways to overcome these with objective ways sometimes can be more helpful with technology. Analyzing large data sets of health systems to identify patients that are particularly higher risk. You're not going to have a person manually going through Epic looking for patients that need things the most. And then also we talked a lot about social economic barriers earlier today, and AI may be a particularly helpful way to overcome racial and cultural biases, because computers don't have biases. Well, not intentionally. And this is another important point, is that what you feed into computers is what you get. So it's important to be cognizant, but at the same time use it in a powerful way. Discovery of unknown risk factors. So sometimes when we're looking at things from a different perspective, it can give us different information. And then also stratification for procedural risk or complexity. When I have a full day of colonoscopy, I don't know who's going to have the more difficult colonoscopy. There's some ideas that you can get, but AI may be another way that we can identify who should be done by Dr. Freeland. Okay, so there are other advances in colonoscopy coming. Polyp recognition, colon mucosal evaluation, scope manipulation, polyp resection we spoke about, new sedation techniques, prevention of complications. AI can be helpful with this, but not exclusively limited to. I did want to talk about some of the AI technologies that currently exist and understand the ways that we can best utilize them. So one of the first ways that AI has been incorporated into colon cancer screening has been computer-aided detection, also called CAD-E. And this is a randomized trial that shows a 30% increase in adenoma detection rate, ADR. And you can see here, there's, I don't know if this picture comes through, but there's a polyp here, and there's a box that goes around it. It can be helpful to point out polyps that we may be otherwise missing. And we can see that there's, in this trial, that there is an improvement in detection across really every area, in small polyps, large polyps, distal polyps, proximal polyps. And this data looks pretty good in this trial. Aside from polyp detection, there's also some evidence that it can help avoid adenoma misses. So aside from, we also want to make sure we're not missing any polyps. And these were, this is a study with tandem colonoscopies where you had one patient undergoing 2 colonoscopies. Half of the patients first got CAD-E, and the other half got high-definition white light. And again, you can see a reduction in the miss rate for a number of different polyps, from the total polyp resection to the polyp miss rates, adenomatous polyp miss rates, and also a sessile polyp miss rate. And it seemed that maybe the biggest benefit was in sessile polyps. This was incorporated 230 patients, and there was a relative reduction of 35% in the CAD-E first group compared to the high-definition white light, with an absolute difference of 10%. Okay. There's been a number of studies since then, and this is a meta-analysis of a bunch of different groups, and you can see all of these groups favor this thing is driving crazy. Okay, all of these favor the CAD-E and the computer detection. There's been some cost-effectiveness trials that also support the CAD-E. So this is a Markov trial that compares colonoscopy with AI to colonoscopy without AI. And based on this model, you see that there's a reduction in cancer incidence, there's a reduction in cancer mortality, and aside from that, there's actually cost savings. So according to this model, the artificial intelligence is a dominant healthcare strategy, meaning that you have both cost savings and life savings. But there's a problem. Why aren't we all using CAD-E based on this data? There's a limitation for a lot of this data. For one, tandem studies can sometimes have more positive data than parallel trials. Endoscopists may be trying harder with some of these trials because it's unblinded technology. Sometimes real-world data is somewhat lacking, and I'll talk a little bit more about that. It's also difficult to power studies for advanced polyps. And so the AI gains that we're talking about here have been in diminutive polyps. And not all ADR gains are equal. ADR is a well-validated quality metric that's looking at colonoscopist performance. But those data are coming from looking at colonoscopists in a larger system. And that may be more reflective of the colonoscopist as opposed to the polyps being captured. So just because we're finding small diminutive polyps may not make that big of a difference. But the other thing is cost effective to whom, right? So the last cost effectiveness trial that I was looking at is looking at it from a health system standpoint. And while these products may be cost effective to a system and to the population aren't the ones that are buying it. It has to be purchased by an endoscopy center. And that's a cost that has to be justified by the endoscopy center to make sure that it's going to fit in with all of the goals of the group. And so one thing that people will say is that when you're finding more polyps, you're going to, let me go backwards. When you're finding more polyps, you're going to have shorter surveillance, so you're going to be doing more colonoscopies, and that's going to offset the cost of the technology. But that may not be true. Plus, that's a cost saving that you'll get over time, but not for the upfront cost of the technology. And this is leading, one of the biggest problems is that payer reimbursement is lacking for these technologies. This is a nice article that talked about some other reasons for the slow uptake for artificial intelligence. There's no legal mandate to measure ADR. Endoscopists believe their ADR is already good enough, so why would I invest money in making my ADR better when I meet the low benchmarks? There's a cost associated, and the costs are immediate, but the return on investment, as we're talking about, may take some time. These systems are all sold as add-on. There's lack of reimbursement, and the price may decrease over time. There's little pressure from either patients or other competition to adopt, and people are also waiting to see what everyone else is going to be doing. So I also want to talk about our experience with AI here at Stanford. So this was an implementation trial that we did here, where we compared patients who would be getting the artificial intelligence system to historical controls and the previous standard of care. Many of you in the room are familiar with this. So we stratified our endoscopist by their prior historical ADR into different quartiles, or tertiles, top, middle, and bottom. And we don't see any ADR gains over the course of this trial with using this technology. We don't see any improvements from the pre-implementation to the implementation over here. And we don't see any improvement either, depending on the prior skill of the colonoscopist. We don't see this in ADR, nor do we see it in adenomas per colonoscopy. So my prediction. So I think CAD-E, there's a role for it, but right now I'm not sure it can be justified based on the cost. And I don't see it getting a broad adoption unless there is going to be additional reimbursement. So I think at some point CAD-E prices are going to come down with increased competition and will eventually become incorporated into standard image processing software. It's a good piece of technology, but I think that we're not quite there yet. Okay, so I also want to talk about CADX, which is similar to CAD-E in that it's an image recognizing software. But instead of using the software to find the polyp, we can use the software to diagnose the polyp. And this is not a new idea. We've been using endoscopy with NBI and imaging to get a sense of what the polyps are going to look like before biopsies for some time. In 2011, the ASGE released guidelines for real-time endoscopic assessment, as well as for resect and discard strategies. So the gist of it is you look at your polyp, if it's small, and you think there's a 90% chance that this polyp is not going to be troublesome, instead of sending it to the pathologist and incurring all those costs, just get rid of it. And CADX provides a really interesting strategy that we can use this technology to be able to reduce the costs associated with pathology. 66% of polyps that on average risk screening are diminutive. So this is a large percentage of our polyps. Keep going. Oops. Okay. And majority of these low risk polyps do not have advanced histology. So this may result with a cost savings of $37 million. And that number comes from a cost effectiveness trial that looked at the strategy of resect and discard. And there's sensitivity analysis here where we can see that the cost savings increase as the feasibility of the technology and the assessment increases. So the better we get with our computers to get to the 100%, there's more cost savings. The cost savings also improve with the pathology costs. So the more expensive pathology, if you're doing less pathology, you get more cost savings. So this technology exists, and this is a trial that recently came out, and it actually, this is a randomized control trial across multi-sites. I believe this uses the Olympus technology for CADX. And interestingly, we don't see any improvements in sensitivity or specificity compared to high-quality assessments of the polyp by the provider. But we do see an improvement in confidence. And I would argue that that is almost as important as an improvement in sensitivity and specificity, because I'm not going to be resecting and discarding polyps if I'm not confident that there's no cancer in there. So even if the technology does not actually improve the sensitivity or specificity of real-time analysis, it may still serve a role in bringing down cost savings for colonoscopy. So that's my prediction, is that CADX will reassure more physicians to consider resect and discard. So there is another movement to use artificial intelligence to improve in quality of colonoscopy. So instead of having to do send my results letter with where the ADR is getting calculated, why not have a computer do it? Have a computer in assessment with ADR and other quality metrics. There are other opportunities to use artificial intelligence to better analyze all the mucosal surfaces and make sure that you're not missing any of the colonoscopy. And this is an example of a 3D rendering of artificial intelligence that identified a missed spot on a colonoscopy and gives you a warning that you got to go back and look around that other curve here. Okay, I want to shift and talk about some other new technologies that are likely coming. We are seeing an increase in blood-based colon cancer screening options. And the CMS has been helpful in defining how good you got to be in order to be able to market this. So FDA approval is one thing, but a lot of our colon cancer screening is covered through insurances because of how life-saving it is. And CMS has determined in order to achieve coverage for a colon cancer screening test, it has to have an indication from the FDA for cancer screening. You need to have sensitivity greater than or equal to 74% and specificity over 90%. These numbers come from the stool-based testing that already exists. Otherwise, 74 sounds a little bit arbitrary. So there's a technology that's locally based here. Guardant is a company in Palo Alto. They've developed a blood test that will detect cell-free DNA. And there's a 20,000 patient registry study that they just had a press release in December, and they achieved 90% specificity and 84% sensitivity, which is pretty good. The problem is that they only had a 13% sensitivity for advanced adenoma detection. So it may be good for diagnosing cancer, but who wants to wait until a patient has cancer? Right? I don't want to be taking out cancers. I want to be taking out polyps. There's another company called Freenome, which used a multi-omic blood test. So multi-omic is where you combine several different omics. That's why it's multi-omic. You have kind of genomes and metabolomes or microbiomes. And they use a computer algorithm with artificial intelligence to analyze blood and to get a better sense of whether patients can have cancer. So this was a cohort study, not a prospective randomized trial like the prior data. And they found a specificity of 94% and sensitivity also pretty good, 91 to 94%. So it's better data than the one we just talked about, although this is a cohort study. And they also compared this data for advanced adenomas, and they detected a 41% advanced adenoma detection, which is comparable to FIT DNA testing in stool. Not as good as colonoscopy, even still, but pretty impressive and may offer benefit for patients looking for non-invasive testing that don't want to get stool. Okay, speaking of stool, there are going to be some exciting stool studies that are coming up in the future. I think many of us have heard of the CONFIRM trial, which is a randomized prospective trial looking at mortality data over 10 years, comparing colonoscopy to FIT. This data is going to be coming out. There is another randomized control prospective trial that's coming out of Japan that's going to be comparing annual FIT testing alone to colonoscopy plus FIT testing, which is not something that we typically do, but it makes sense. If we're looking for missed lesions and interval lesions, maybe combining a non-invasive test together with the colonoscopy is the best approach. And there's another randomized trial that is going to be coming out with further data over the next 10 years. I wanted to go through some of the interim data to get a sense of what we can expect from these trials, to give us a flavor of how we can expect stool-based testing to compare to colonoscopy over long term. So this is an interim report that the primary outcome is going to look at death of colorectal cancer at 10 years. They randomized patients from aged 50 to 69 to one-time colonoscopy in 20,000 subjects versus FIT every 2 years in 27,000 patients. And this was interim data after 2 years, so it's really only just the first batch of the FIT testing. And they also are looking at intention to screen as well as screened populations, which is an important distinction. So one of the things that I found most interesting from this was the rate of participation. And the rate of participation in the FIT group was 34% versus 24.6% in colonoscopy group. That's still pretty low, right? So that means if you're telling someone to get colon cancer screening in a study setting, you're still only getting about a third of the patients. Importantly also, you see a lot more people willing to do FIT testing than colonoscopy. There's almost 50% more people doing the FIT group compared to the colonoscopy group. And that's especially important when we're going to be talking about the intention to screen, comparing them to the as-screened populations. So they found cancer in similar groups. So cancer was found in 30% in the colonoscopy group compared to 33% in the FIT group. So there was not a big difference there. They did find more advanced adenomas as well as non-advanced adenomas in the colonoscopy group compared to the FIT group, although the odds ratio is not that big. And again, this is the intention to screen as opposed to the as-screened populations. When you compare the two analyses, you see that the odds ratios in the as-screened group are much higher than in the intention to screen. And that makes sense because a lot more people are getting the FIT versus the colonoscopy. So if you're diluting your data by including people that didn't actually get the intervention. And that's important too when we're thinking about what these trials are going to show when they come out. Because if the primary outcome is looking at intention to screen, but patients aren't getting the screening, then it's going to be a lot harder to show improvement. So there are some other trials that were not prospective, or these were population studies that were done in Korea that were looking at colonoscopy versus FIT in large outcomes and large databases. And these are two separate studies here looking at claims databases between patients that had colonoscopy versus patients that had FIT. And interestingly, you can see a dose response for the number of FITs. The lower number is better. That means that your risk of colon cancer is going down, the odds risk. So patients that had more than five FIT tests had less colon cancers, and colonoscopy still appeared to be better. A diagnostic colonoscopy still had less odds risk compared to even the most aggressive FIT, even for patients that had EMR or prior polypectomy. And this is a separate study also coming from Korea that was looking at comparing populations. The top graph is people that did not have any screening at all, and this is overall survival as opposed from diagnosis of colon cancer. Then you have the FIT, which is the red bar, and then colonoscopy, green bar. Okay, so my prediction. I think intention to treat analysis will show improved outcomes versus FIT due to better adherence, but per protocol analysis will favor colonoscopy. And again, this is a prediction, and I may be wrong. I also think that everyone's going to get this all confused. And this is a very subtle message to convey to patients. And it's going to be our jobs as gastroenterologists and other people in the field here to make sure that we communicate this data with shared decision-making. Okay, I want to talk about, I think we're a little over, but a randomized controlled trial comparing colon capsule endoscopy versus CT colonography. So there are other non-invasive ways to screen for colon cancer other than with colonoscopy. And these were pretty similar between capsule endoscopy versus CT colonography. And so I think the decision to choose them comes down to whether you can get a good bowel prep. If you can't get a good bowel prep, then you have to be very careful with capsule colonography. And my prediction is I don't think capsule colonography is going to be adopted as a first-line screening test because of the rigorous bowel prep. Patients need to take a more extensive bowel prep for a capsule than for a traditional colonoscopy. And then what do you do if you find a 5-millimeter polyp? They have to do a third bowel prep. And so I don't see that being adopted as a first-line screening. So some takeaways. Colon cancer screening has some strong and increasingly supportive data. Stool and blood tests are probably maybe become an increasing share of colon cancer screening for average risk patients. And I don't think that there should be any fear here with this. We need to use every test that we have to be able to capture as many patients as possible. And it's important for patients to be aware of all the different options that they have. AI is here, but the value and the cost is unclear, and it's going to be interesting to see how this shakes out as far as utility and adoption. Capsule and CT, I do not think will become first-line screening options for most patients, but maybe options for patients with difficult colonoscopy who are otherwise unwilling to have an interventional procedure. And the most important thing is that I think shared decision-making is going to be increasingly important as the data becomes more complicated and our options are continue to expand. Thank you very much. So I'll just repeat the question for the audience. The question was, how can we justify the Barrett's esophagus screening on a population level?
Yeah, so that's a great question that I think people are interested to answer. I think at this point with the data we have, we cannot justify kind of general, universal screening for Barrett's, if that's what you're asking, if I understand correctly. Barrett's exists in, up to 5% of the population. However, the risk for progression is very, very low. And so, at this point, we cannot really justify it. I think the way to move forward is to potentially improve our ability to risk stratify patients who are at risk for Barrett's. And so, I think we have a good starting point, right? All our clinical criteria to determine who is at risk. But, there are issues with this. Some of the criteria, such as like family history, has a much higher predictive power than things like, obesity, right? Which affects like 30% of people. And so I think figuring out how to weight these differently or potentially integrating them into better risk scores will be helpful moving forward.
Can I ask a follow-up to that?
Sure.
So the new AJA guidelines say that you don't need GERD. So let's say you have a white male greater than 50 years old so that meets criteria for screening. What ICD code are you going to use for that procedure?
I think that there's some argument to be made that you could use a screening. I think a screening diagnosis. However, I kind of agree with you. Like, what do we do with these patients? That's a lot of our patients, right? And I think that, it's something I might discuss with a patient, but there are actually some studies that have come out looking at the cost effectiveness of screening certain populations. So, you could potentially argue that there was a cost effective analysis looking at screening in white males, white females, black males, black females. And they did find, I think at a threshold of $100,000 per quality that it was justified or cost effective to screen white males in that population. But, I think that that's a problem that we need to tackle.
Yeah. I think also as we get better at risk prediction, then it won't be so expensive to diagnose somebody with Barrett's esophagus. So if this TissueCypher and other technologies become more readily available, it may be easier to convince. Yeah. We have a question, John. I'm not getting them.
Have about 10 with the iPad.
Oh, how do these? I don't see anything here.
Okay, let me go for. So it looks like on yours it's not coming in. I've got them all here though.
Okay.
If you want to take those.
Sure. Okay, thank you.
Yeah.
Okay, so we have a question here. When would you utilize over the scope versus full thickness resection versus, I'm sorry, when would you utilize over the scope full thickness resection versus ESD for residual polyp scar?
Well, we didn't really get to that in the thing. The over-the-scope, the question is when to use the over-the-scope full-thickness resection device. That has the advantage of going full thickness. If you're concerned that the lesion, you're not going to be able to get the full lesion, the full depth of the lesion by ESD, for example, if there's so much fibrosis that you can't ESD it off the muscle, then you might use that device. It's limited to relatively small lesions, about 2 centimeters. To me, it's perfect for subepithelial small lesions because that's really when you want to go full thickness. If it's a small lesion in the muscle, I don't use it that much in the colon, except if someone sends me a scar of a malignant polyp and the surgeon wants to know is there, the margins were positive, it's a poor surgical candidate. We really want to know is there any cancer left that could possibly be in the muscle just under the mucosa. Then I use that device.
Okay, great. And I have a few questions here. Any data comparing the value of Cologuard with colonoscopy? So that's a tricky question. I'm not sure if they mean by value from a cost effectiveness standpoint or value from a polyp detection standpoint. There's no long-term randomized trial data looking at mortality from as far as Cologuard versus colonoscopy, and we're expecting that with FIT. But Cologuard is validated, and I think the advanced adenoma detection rate is about 40% compared to colonoscopy. As far as cost effectiveness, Cologuard is not cost effective compared to FIT for colon cancer screening. But that being said, if I had a patient who's higher risk than average and really didn't want a colonoscopy, I would go with the most sensitive test I could find. If anyone has anything, okay. How do you determine surveillance utilizing CADX without available histology if no other lesions are obtained on this procedure? So that's a great question. So CADX, the goal would be to utilize it in the same way that you would use pathology. So if CADX is able to tell you that the polyp is a hyperplastic polyp, treat it as a hyperplastic polyp, and I think the surveillance intervals would be similar until there's data suggesting otherwise. Was CADX based on rectosigmoid polyps? I believe CADX, that trial was looking at CADX throughout the colon, so not just in the rectosigmoid. And it was a question for Dr. Park. Do you have patients for whom you personally stop cyst surveillance?
Yeah, primarily patients who are frail or have significant comorbidities where an operation would be unlikely for them. Whether age is an appropriate, perhaps, but it all depends on really on their health and their fitness and their goals and their and their goals in care. So it's really a case-by-case discussion.
That's great. I have a question also. So I've run into a situation where I have a patient with dyspepsia. Someone gets a CAT scan, they find a pancreas cyst, and they are convinced that the pancreas cyst is causing the dyspepsia. What do I tell those people?
Exactly what you, that it's unlikely to cause their pain, it's their dyspepsia.
Yeah. So there's never symptomatic. That's what I thought. Okay. Given concern by some patients that H. pylori eradication may have potential downsides, more acid production, possible food sensitivities, are there any patients that you would treat, any patients you would not treat in incidental positive H. pylori?
No. So it's established WHO class 1 carcinogen. Potential side effects, might include an increased incidence of GERD-type symptoms, acid reflux, but this has never been shown to increase risk for esophageal cancer. There's a small concern for, I guess, dysbiosis in terms of, you're introducing antibiotics, but actually the studies have shown that after eradication of H. pylori, bacterial diversity increases in the stomach. Really, I think it behooves the clinician, if diagnosed, to treat it, or at least to make an attempt to treat it and document that you discuss treatment with the patient. And if they decline treatment, then that's ultimately their decision. But you should be treating it.
For Doctors Zhao and Wang, often there is a question about whether metaplasia at the EGJ is short segment Barrett's or GAM. If surveillance recommendations are similar, does that distinction matter?
So I didn't really get into the cardia metaplasia. Probably cardia metaplasia is more similar to Margaret's topic of Barrett's. The epidemiology and the risk factors are all consistent more with Barrett's esophagus. Right now there's no kind of good data or guidelines about what to do with cardia GIM, but in terms of kind of what it is biologically, it's probably more, it's probably Barrett's or similar to Barrett's.
Yeah, totally. And I think that, there is still some debate in the field. I know our guidelines now are saying at least 1 centimeter above the GE junction. I think, what to do about like irregular Z lines and cardia IM or kind of, IM found just that the EGJ is still kind of being sorted out. And I know Dr. Speckler kind of wrote about this recently, so maybe we'll hear more.
Okay. If a patient tested positive for H. pylori, do you recommend their family members in the same household get tested as well?
Personally, I do. I do. There's no kind of, we don't have that societal guidance, but I think that it's such a low cost thing to do just to get a stool test. It's non-invasive and the treatment is very relatively benign, just 2 weeks of antibiotics. So actually, interestingly, the USPSTF, the Preventive Services Task Force, is taking up a nomination this year of screening and treatment of H. pylori for the general population, or at least adults over the age of 18. So everybody in this room. So that would be, we'll see what they say, but I personally would recommend it, yes.
That's great. Okay. And lastly, why are cardia biopsies not obtained with gastric mapping?
Because kind of the prevalence of cardia IM is probably much, much lower, orders of magnitude lower than for antrum and body. So most places of the world, you're looking at 90% it's H. pylori. In US, it's probably 30-40% autoimmune, 60-70% H. pylori. Cardia IM, I guess it's less common, and also probably because most of the risk is encapsulated kind of within the Barrett's component. I mean, you do get cardiac cancers, but that was just never it wasn't covered initially in a lot of these consensus topics because everyone kind of thought that biologically it was more similar to Barrett's and esophageal adenocarcinoma. Yeah.
Just to add to that, I think that, there is still ongoing debate about how to classify cardiac cancers, like are they more esophageal or gastric? And I think as we understand more about the epidemiology, pathophysiology of this type of cancer, hopefully we'll sort out the risk of IM in the cardia too.
That's great.
Can I just go back to Morris? I think most of us agree with what you left us with from corridors, that we want to do this, but do this as well. How do you apply that principle in your practice to, make a difference on our little sphere of influence that we have?
Is this on? Yes. Okay, great. I think that in terms of our, so that's really talking about population, of course. And actually, a few years ago, I met a professor from the School of Education here at Stanford, back when I was at Michigan. we were talking about our work and his work on equality in education, my work on equality in healthcare. It was really interesting. He told me that the educational system with the K through 12 educational system with the greatest equity in the entire United States was in the city of Detroit, the poorest city in the United States, because they were all the same at the bottom, or at the very bottom. It was quite an eye-opener to me thinking about equality. Like we don't want to make everybody equal by making everything worse. How do I do that personally in practice, which is not, since I'm not addressing people at the population level in my practice, is I think by trying to stay cognizant that I probably am not seeing the whole picture of what the patient that I'm interacting with is dealing with. Sometimes even in the process of getting to a clinic appointment, I recently learned that a patient had taken 4 buses to get to my clinic appointment. They were transitioning from bus to bus 3 times just to get to the appointment on time. It's really tough. I think trying to understand that when, for example, if patients are late or when they seem like they're just not adhering. We just had this discussion. You agreed you would do this last time that we met. What happened? I think asking questions where they're not rhetorical questions, where we're really looking for an actual answer to understand the other person's experience can help. I think engaging family members and important others is critically important. And we've done some studies looking at engaging the family members so that there is that support at home. It seems to be very effective, actually, with getting cancer treatment, at least.
I think we're done. Yeah. Okay. Anything else? Great. I think that concludes. Thank you very much, and it's been a pleasure.